I'm going to go ahead and share my screen. So Dr. Nelson,
Hey,
hello.
it's good to be back. Good to be back. I've been tuned in the whole day, and first off, you must be tired, Dan. You're really working hard today, so I'm recognizing that. I just am amazed at the quality of every single presentation. It's been phenomenal.
Awesome. So this last hour, like I mentioned, is going to be a live case. It's essentially going to be like you're in the emergency room with us. We have Dr. Nelson's an emergency physician, right? I'm a
Correct.
gastroenterology fellow, so maybe not as much of the emergency side, but I was an EMT for a while, so that counts too, right? And so we have a cool case that we're going to pretty much walk through, but we need your help. This whole time, we're going to ask questions nonstop. We need your answers in the chat. We want your thoughts about how to approach this case, what you would do, what we should do next, because this is essentially like a live situation. So we're going to get started with the case, and I'm just going to read it out loud. You guys can all see my screen, right?
Yep.
Okay. So we have a 32-year-old female, a restrained driver going 40 miles an hour when she was hit head on by another vehicle. She was unable to self-extricate and has severe lower abdominal pain. C collar is placed. Blood pressure on arrival is 70 over 50, and heart rate's 140. She's gotten 1 liter of IV fluids, and a repeat blood pressure is 85 over 65. She's not on any blood thinners and has had no loss of consciousness. So this is what the triage nurse tells you down here. Reports abdominal pain, looks pale, blood pressure is 68 over 49 now, with a heart rate of 145. And you meet this patient in the resuscitation bay. So before we even get started, Dr. Nelson, what are you thinking here, and what should we be doing?
Sure. Well, first off, um, over my 20 some years of working in the emergency department, I always had students with me, and it's fun to go through scenarios like this and kind of talk about what's the best approach to this. And as you'll see, there are varying approaches to it. So, what I do might be not what somebody else would do. But when it comes to critical care patients, there are certain things that kind of keep us all doing best practices. So what comes to mind for me right off the bat is those ATLS courses that I've taken over the years, advanced trauma support courses, which because of adrenaline kicking in these scenarios, they give us algorithms. So starting with that algorithm of the A, B, C, D, E's.
Perfect. So we're going to begin, and we're going to need all of your assistance and everybody in the chat. Like, what should we do? Treat this as pretty much like a live case. Let's begin. Okay, so the patient's right here, laying here. We have the information on the left. And just to read off a few pieces of information, just a past medical history of asthma and seasonal allergies, just as albuterol is needed as a medication with loratadine, no known drug allergies, a non-contributory family history, no alcohol or social alcohol use, denies tobacco or illicit substance use. So that's
And
the
we might not even have that much,
yeah.
depending upon, if it's a short transport or if the patient was obtunded and wasn't able to give kind of that background history to the EMS or triage nurse. So we might know zero of that going in,
Sure.
which, is helpful to have it. But if you don't, you just kind of proceed forward with your best foot forward.
Absolutely.
So yeah,
So we
let's
got a
start
little
with
bit of
A.
we got some history about vitals, right? But we need to know what they are now, right?
Right. So let's get some cardiac monitor on this person. Let's have somebody do a blood pressure and a
So
pulse.
we have a blood pressure there of 68 over 49 and a heart rate of 146, temperature is 37. O2 sat is 90 to 91%, and respirations are at 22. So everyone in the chat, write what your thoughts are about those values. Like, are they normal? Is the heart rate normal? Is the blood pressure normal? What's off?
And what would you do first? What
Yeah.
would you do first? I know what I would do. It's we kind of want to treat what's right in front of you, that low blood pressure, but I still would start with that A, that airway, and make sure that the patient's airway is patent and there's nothing obstructing it. And
So
then
you're
go,
saying let's do an exam.
yeah, let's do an exam.
Happy to do an exam, and we're going to address all those vital signs shortly. So you said airway is the
Yep.
first thing you do. So the airway is patent without obstruction or stridor. What about next?
I would do B, breath sounds.
All right, let's do the breathing exam then. Bilateral symmetric breath sounds with normal chest rise.
So we can be assured that those are okay. So now we can go to C,
Okay.
which
Let's go back
part
to
of that is that low blood pressure.
ready pulses in all extremities with mottled capillary refill greater than 4 seconds. So you mentioned it's related to the blood pressure?
Correct. So now you intervene. So you don't intervene on those until you get to that kind of initial assessment piece. So for example, if we had an obstructed airway, we would take care of that before we would go and start in on the blood pressure.
So what's everyone in the chat saying? Write to us, what vital signs are you most concerned about right now? And Dr. Nelson's going to read out some of the responses in the chat.
Okay, so in the chat so far, okay, whoa, they're really coming in. Blood pressure, blood pressure, blood pressure. Respiratory rate, somebody said, heart rate, oxygen and blood pressure, high heart rate, vitals. I like it.
Both
Good
vitals,
stuff.
vitals, absolutely. So then kind of going one by one, is that a normal heart rate?
Not in my book.
So what would normal be then?
For me, normal is between 60 and 100.
All right, so that's clearly very high then. And then same with the blood pressure. I mean, that's a quite a low blood pressure there, right?
Exactly. And blood pressure is a bit more variable, depending upon, if they're young, healthy, whatnot. Even with pediatric patients, if they're, 2 years old versus if they're, 16 years old, there's different blood pressure parameters. But we like to see that systolic blood pressure over 90.
Gotcha. Okay, and then what about the that number in blue, the oxygen saturation at
Oh,
80,
yeah.
90, 91%? What's normal for that?
Well, normal, I would say, is over 94%, but young, healthy people, we generally see them 98, 99, 100%. So let's put this patient on a non-rebreather oxygen.
Okay, let's do it. So we can stabilize the patient here by giving some oxygen. And so some of the options here are actually nasal cannula oxygen, non-rebreather mask, and bag valve mask. What made you say non-rebreather mask, say, as opposed to a nasal cannula oxygen?
The other non-rebreather versus mask versus nasal cannula, you get a higher concentration of oxygen with a non-rebreather. You get near that 100% oxygen being administered versus a nasal cannula, you might get 40 to 50% oxygen, and a mask might be 60 to 70% oxygen.
So
So
we
just
can
that higher concentration.
like you said, then let's do the non-rebreather mask. And I think it's important to then keep looking at that blue number and see if what we do impacts it. So now we've put on the non-rebreather mask. And so that number just jumped to 99%, 100%. So
Excellent.
it worked, right?
Absolutely, because if some of her organs are not being ideally perfused from the trauma, we're now trying, creating less of a watershed area and less ischemia to those cells.
Gotcha. So what should we intervene upon next? Everyone in the chat, should we focus, is there something else that we should be doing right now, like right now in this acute setting?
Well, somebody said intubate if it becomes unresponsive. I agree with that because they're no longer able to handle their saliva, their secretions. But we're okay now. The patient is able to interact with us. See, ultrasound immediately in CT and X-ray. Update blood pressure, heart rate, physical exam for wounds.
Okay. So what should we start with? Should we stabilize first or do an exam? Completely up to you, Dr. Nelson.
Let's do some stabilization
All
first.
right,
So
let's stabilize. So,
let's this patient's already had some IV fluids en route, so let's do some blood. Let's do some
okay.
uh, uncross-matched O negative blood,
So then we have packed red blood cells. Is that what you're referring to? Is that what we
please.
start with?
Yes.
1 unit or 2 units in
Let's
one
do 2 units right now. Otherwise, if we just keep giving fluids, the patient's blood is going to get diluted. They won't be able to have a chance to, their clotting factors will be diluted. They'll start bleeding more. So if the patient's already had a lot of fluids already, we can give more fluids. But in addition to that, we start giving packed red cells.
Absolutely. So we just inserted an IV. It alerted us that we definitely need to have an IV in to get some blood. So then we'll do that. And you said 2 units of packed red blood cells. So we'll click
Yes.
twice. All right, here, one more. And now 2 units, if you see here in the background, there's a little blood hanging back here by the monitor. And now the blood pressure is slowly improving to about 90 over 65. And the heart rate has come down a little bit to 120s. All right, that's good. Things are getting a little better. Not great, but better.
Absolutely. And I would also continue with the IV fluid infusion. I know they started in route, but I think we have to continue that here for our patient.
Okay, so let's see where we can find some more fluids. Maybe we have that here. Resuscitation medications, right? Well, not those. Fluids down here. Okay, there's a lot of different fluid options. There's like
Right. So we
infusions, normal saline, boluses. What should we do? And everyone in the chat, what are your thoughts about kind of which fluids to give here? And then Dr. Nelson's going to evaluate.
right. Let's see. I should have taken a beta blocker before this presentation. That's good. Perhaps
What is it?
neosynephrine for a pressor. We don't want to go there yet. So we want to maximize our fluids for saline. Somebody said D5 half normal saline. Mostly people are saying normal saline. I agree with the normal saline. The
Okay,
D5 is the dextrose is glucose, and we're going to inappropriately raise the blood glucose. So we're going to stick with normal saline, or we could give lactated ringers. Both of them are crystalloid solutions. They're going to stay in the vascular system, and that's what we want it to do to keep that pressure as high as possible.
perfect. Should we give a liter? Should we give 500 cc's?
Let's give a liter. Yep.
Okay, we're going to give a liter of normal saline then. Let's do that. Let's perform that. Okay, excellent. So we'll see how that blood pressure and that heart rate responds. So now we've done a little bit of stabilization, which is good. But we definitely need more information. So we've done the exam for airway, breathing, and circulation. Are there other exams we should be doing?
Yeah, in fact, somebody's concerned that maybe she's pregnant. So,
Oh, okay, we're gonna have to get to all of that as well for
yeah, we'll
sure.
have to look into that for sure. Absolutely.
Uh,
Somebody's saying we better do an abdominal exam and a urine
okay.
test. Yep.
So there's a lot of exams here that we can perform, and we can really go in any order here. But I'm gonna say the exam. You, Dr. Nelson, tell me if you think we should do it or not. This is
Sure. Yes.
all right. Let's see. Pupils equal and reactive. Patient moves all extremities. No sensory deficits. Exposure exam.
Yes.
Okay. There's the patient gets fully undressed. There's no obvious deformities, but there is significant bruising of the right flank.
Okay.
Okay, that's important to know. What about
Noted.
head, ears, eyes, nose, throat?
Absolutely.
All right. So, conjunctival pallor. What does that mean, conjunctival pallor, Dr. Nelson?
It means that our conjunctiva is the skin inside of our eyelids, and it normally is nice and pink. But if you have anemia or acute bleeding, it's going to look whitish or pale.
Gotcha. And then also there's an abrasion to the left cheek without deformity or bruising. Normal cephalic, pupils equal, round, reactive to light, PERRL here. And then extraocular movements of the eyes are intact and the oropharynx is clear. Okay, what next?
I would carefully take off the C-collar and palpate the neck, kind of
Okay.
going just down.
Here. Mild tenderness to palpation of lateral aspects of the neck bilaterally, no masses, trachea. Is midline, no C-spine tenderness. Okay, so that tenderness of the the lateral aspects of the neck bilaterally, what is that
Sure.
called?
It implies that there's some muscular tenderness, but I want to see in the chat if people think we should keep that cervical collar on and keep C-spine precautions, or if we can take that, you know, big bulky plastic C-collar off. Keep C-spine. Yes, keep C-spine. Good, very good. I agree with you. Because there's a distracting injury, the patient isn't able to attend to that exam as well as we want them to, so we want to keep them in C-spine precaution.
Really good point. And so there's now the cardiovascular exam that we can perform,
Yep.
which shows tachycardia, or just a fast heart rate with a regular rhythm, no murmurs, rubs, or gallops. And then, should we do the pulmonary exam?
Yep.
Pulmonary exam shows tachypnea. There's crackles to the mid-lung fields bilaterally. Otherwise, the lungs are cleared auscultation, no retractions, wheezes, bronchi, or rales. So what does that tachypnea and those crackles mean? We can ask in the chat first and see, what do
Yeah.
crackles to the mid-lungs mean? What does tachypnea mean?
Just to give additional information, crackles, it sounds like Rice Krispies, that cereal when it put milk on it, popping when you're listening to the lungs.
What are we seeing in the chat here about?
Fluid in the lung, fast breathing, fluid in the lungs. What fluid? Crackles, let's see here, pleural edema or subcutaneous emphysema, cracked ribs, blood. There it is. There's the right answer.
There's some blood there. It's very possible because we don't
Yeah,
really know all the information yet. So we have to continue on with the physical exam. And we can move on to the abdominal exam here then,
do that.
which says severe tenderness to palpation of the lower abdomen with voluntary guarding but no rigidity. The abdomen's otherwise soft. The pelvis is grossly unstable to gentle inward and posterior pressure. and posterior pressure over the pubic symphysis. So that's a lot of information right there, right? What are you thinking about all of that?
That I'm very concerned now, very, very concerned. I'm thinking that we might need to get some other people to help us intervene on this. The tenderness of the abdomen makes me think there's some bleeding internally. And then that pelvis exam really is concerning for an unstable pelvis fracture. And be interested to see you guys as a response in the chat. What major complication or mortality can happen from an unstable pelvis fracture? Damage to internal organs? Yep. Massive bleeding. That's exactly right. You can exsanguinate or bleed out and die from a pelvis fracture due to a significant amount of pelvic veins that run on the posterior aspect of the pelvis. And if that pelvis is unstable and movable, those veins can shear and break open.
Gotcha. So that exam was very telling, and there's a few more pieces of information we can get. So then we move on. Do we need to do the genitourinary exam, do you think, and why?
Absolutely, because a pelvis fracture can disrupt the urethra, and this patient's most likely going to end up in the operating room and require a catheter. And we want to see if there's any potential damage to that urethra before a catheter is placed.
Gotcha. So let's do that exam, and there's no rectal or vaginal bleeding, but there is mild bruising to the labia, no blood at the urethral meatus. Okay, so moving on now to the back and flank exam. There's no tenderness to the thoracic or lumbar spine, but there's severe tenderness to the sacrum and bruising to the right flank. So another piece of information there for us, right?
Yep.
All right, and now musculoskeletal exam. The hip range of motion is deferred. Why do you think it was deferred?
Let's hear from the chat. Why is that hip range of motion deferred? Pelvis injury.
Yeah, we have to be very, very careful. So with
Yep.
lateral movements of both sides of the pelvis with gentle downward and inward pressure, there is lateral movement. There's no tenderness of palpation of the thigh, knee, lower legs or ankles, and there's a normal range of motion at the bilateral ankles, shoulders, elbows, and wrists. Compartments are soft, no clubbing, cyanosis, or edema. Okay, wow. Two more exams that we can possibly do. Skin exam, yes or no?
Yep.
Let's do it. The skin exam shows scattered abrasions, diaphoretic, bruising to the right flank. Extremities are cool to the touch with no rashes. What does that extremities cool to touch signify in the chat? Like, what are we thinking when you're doing an exam and the extremities, the arms and legs are cool to the touch?
Low perfusion, right? Exactly. Blood's not circulating. Ischemia. And your body's smart. It's vasoconstricting in those peripheral vessels, pushing as much blood to the central organs as possible.
Absolutely. And now the last piece of information on the physical exam is the neuro exam, which says bilateral strength testing of the bilateral, limited strength testing of the bilateral lower extremities secondary to injury. But the patient has 5 out of 5 dorsal and pedal flexion strength, awake and alert, speech clear, cranial nerves are intact, normal bulk and tone in all extremities, normal strength, bilateral upper extremities, no drift or dysmetria. Okay, so we've gotten a lot of information on the physical exam and the vital signs. I want to hear in the chat what people are starting to think of that exam, which had a lot of like notable findings, right?
You
What are we
really did. That was fun. How long are these tests taking? How long is it viable to wait for a patient? That's a good point. So a lot of these things are kind of happen simultaneously. We're going linearly just for, educational sake, but a lot of things happen all at once. Somebody said they wanted abdominal CT, CBC, a pregnancy at minimum. I agree. I agree. There's some other things we might add to that as well. But what we did was we just did something called a secondary survey, which is the head to toe physical exam in a multi-trauma patient.
Yeah. So we've done the primary, which is like the ABCs, the vitals, and then we did that secondary survey. So we've done a physical exam, we have the vital signs, and we've also already done some interventions. We've put in an IV, we've given 2 units of packed red blood cells, we've given a liter of normal saline bolus, right?
Yep.
And now the vital signs, like we talked about, have changed a little bit. So that's something we should continue to monitor. So the heart rate's currently 113, 118, temperature's 37, oxygen's 99%, blood pressure's 94/67, and the respirations are 22. Do we need to do anything more about the vital signs right now, or should we get some investigations going? What is everyone's thoughts about timing all of this?
Let's see here. Investigations, blood pressure still low. Let's get some blood work, do some more investigating. Resting rate's still 20. So I would intervene just a little bit more before the investigation. I would order a second IV in case we
Okay.
need, or even a central line.
So we can put in a second IV here right now. Why do you want a second IV? We already have one.
That way we can give both blood and crystalloid, and if this patient continues to bleed rapidly, as well as other medications.
Okay. So we've put in that second IV now. What else?
So we have a non-rebreather on, we have two IVs in, we have blood going, we have fluids going. We don't want pressors. Somebody had mentioned pressors earlier to try to bring the blood pressure up more because that's actually going to make the bleeding worse. It's going to kind of push the blood out through those broken veins. So we want to continue with our fluids and our blood as far as blood pressure management. I would say we start investigating.
All right, let's start investigating then. We've given a couple of units of blood, we've given some fluids, we have the IVs in. We're going to watch the vitals carefully this whole time in case anything changes because it's a live case, right? Like it's happening as we're doing these investigations so we can keep real-time monitoring going. But let's investigate. So the ways that we can investigate here in the system are through bedside tests, through lab work, and through imaging. So like maybe we start with some options for bedside tests. And here's what it gives us. We can do a Doppler, EKG, finger stick blood sugar, some ultrasounds, some different types of ultrasounds, and maybe looking at these bedside tests, what jumps out as possibilities that we can use right now in the resuscitation bay of the emergency room?
I would do a POCUS, point of care ultrasound fast exam, um, while they're drawing blood and sending that to the lab. So
Okay.
I would
What
order
makes
the
you want to do
labs.
a fast exam? What is a fast exam?
Fast exams stands for focused abdominal sonographic trauma exam. And it's an exam looking for internal bleeding of the abdomen and pelvis in blunt trauma.
Okay, so we know this patient went through a trauma, so sounds like a pretty reasonable test, and we'll do everything individually now, just as we're working through the case. But let's order this ultrasound, this fast exam, and see what the results show. There
And there's
is,
some good stuff in the chat too. One person asked what a pressor is, and the pressor is a medication that elevates your blood pressure by causing your arterioles to vasoconstrict. Somebody else said an EKG. I think that's an excellent idea at some point. And some others uh, talking about doing an ultrasound. Okay.
okay. So we did the ultrasound, the fast exam, and there's no stripe in the bilateral upper quadrants, no pericardial effusion or fluid behind the bladder, and bilateral lung sliding is present. What's bilateral lung sliding? Why do they mention that?
So bilateral lung sliding is a pretty minute finding on a ultrasound of the lungs that implies that there's no pneumothorax or collapse of the lungs versus there still could be hemothorax or bleeding within the lungs, but there's no collapse or pneumothorax.
Gotcha. And somebody else, so we got the ultrasound done here, the fast exam. Somebody mentioned an EKG, and we can do an EKG. I'm curious why, whoever wrote that, I want to hear why do an EKG right now? What are you looking for? What are you concerned about that you would want to do it?
Let's see, no response yet. I can tell you what I would be concerned about.
Mhm.
We have some indications that there's some chest trauma, there's some abnormal lung sounds, there's tachypnea or fast breathing. There could easily be a cardiac injury, a cardiac contusion, which would then cause some abnormalities on the ECG.
Makes sense. And also, we don't know yet why this accident occurred. Maybe
Good
the
point.
patient had a heart attack or an arrhythmia that that caused something, right? So we don't want to miss it. So that's a very good point. Whoever said EKG, let's do that. So EKG. EKG is done. Let's take a look. Okay. What do we have here? We have an EKG here, and it's the quick interpretation is sinus tachycardia without ischemic changes. But Dr. Nelson, when you're looking at an EKG in the emergency room, what are the things that you look for as like a quick and dirty evaluation? Because there's a lot of nuances to EKGs, and even
There is.
like even after I've gotten my internal medicine like board certification, I technically have to know this, but there's so many details, and I'm not pursuing cardiology. So, well, what's the way that you would approach it?
Right. First off, I look to see if there's any arrhythmias, which we would also see on the cardiac monitor, on the telemetry monitor. And I do see an arrhythmia in the fact of sinus tachycardia, but no other like uh, aberrant arrhythmias like VTach or VFib.
Okay.
Um, and then what I look for are kind of the ischemia infarction signs like ST elevations or ST depressions, where the segment between the QRS complex and the T wave repolarization will either rise up or lower, and that implies the lack of blood flow to certain areas of the heart muscle.
Gotcha. Okay, so the EKG is now done. We've evaluated it quickly. It doesn't sound like there's anything in particular on the EKG that's concerning beyond the sinus tachycardia that we already knew about, that fast heart rate. So we can put that to the side for the time being and continue our evaluation with all the additional tests that we have at our disposal. So, we did the focus already. We did that fast exam. Should we do an ultrasound of the heart and of the lungs as well?
I wouldn't do any further ultrasound at this point because I think we can get better detailed images with a CT scanner.
Okay, absolutely. So let's get more information then with other ways. Should we do the CT scan first, or should we get blood work first?
Let's
What is
get
that?
blood work first. That way it can start cooking in the lab.
Okay, absolutely. Should one of those pieces of blood work be a quick finger stick blood sugar?
Yes,
Okay, and why do we do that?
because that's something that if it was abnormal, we can quickly intervene and take care of it versus waiting for the lab to give us a glucose report.
Gotcha. So maybe if
And
the glucose is really low, it means that maybe that contributed to passing out and causing an accident, right?
exactly.
All right, let's do that and let's see what the result is of that glucose test. 89, which is normal, right?
Perfect.
So lab work, there's a lot of options for blood work that we can choose, and I can read through them, but everyone write in the chat based on the things that you're seeing here. What are some of the important blood work items that we're
CBC.
ordering? Okay,
Another CBC.
okay. A lot of people are saying
CBC,
CBC.
CMP. Oh boy. Type and screen, coags, troponin. That's excellent. Way to go, Alex S. That was excellent. I
Okay,
agree with
so I
Alex
heard
S.
CBC was a common one, and I think maybe let's start by doing each individual lab. We'll order it individually, and then we'll review that test as we order it to make sure it was something that was abnormal or normal. Okay, so I'm ordering the CBC first, and let's perform that test. And again, we would send all of this blood work in one go, and we'd get the results as they come back. But starting off with the CBC, the white blood cell count here is 19, right, or 19,000. And this software is amazing that it highlights the abnormal results in orange, which is great. The hematocrit is 24%, the hemoglobin's 8, and the platelets are 360. So what is standing out already besides obviously just seeing that it's orange? Like, what are people's thoughts about this CBC right away?
Some people are already commenting that the white count is high,
Mhm.
anemic. So the hemoglobin and hematocrit are low. Possible sepsis, infection. Hemoglobin is only 8 after receiving 2 units.
Yeah.
Sepsis. So
So we see that the white blood cell count is high, right? 19,000, indicating a leukocytosis. And we also see that the hemoglobin's 8. What's a normal hemoglobin?
different for males and females. Normal for females is greater than 12, less than 18, I believe. And then males, I think, is greater than 14, less than 19.
So we have a level of 8 here, and that's kind of low.
That's
So
pretty darn low.
what does that tell you right off the bat, just the CBC? What are you concerned about with that anemia?
That the bleeding is even greater than I anticipated.
Yeah, there's a lot of bleeding going on, and that blood loss is somewhere. So there are certain places that bleeding can occur, right? So what are the different parts of the body that blood can get trapped in and you can bleed out into those areas? What's your approach when you think that there's trauma going on with bleeding, Dr. Nelson?
Yeah, the first one is the abdomen, and we kind of ruled that out with our fast exam. Another space that people can bleed out and die from is the anterior thigh or from a femur fracture. You can put enough blood into the thigh from a femur fracture to die. But for this particular case, I'm worried about the retroperitoneal cavity, the space that's in the back of the abdomen but doesn't have that intra-abdominal compartment to it. It's where the kidneys live, it's where part of the pancreas lives, and it's where the back of the pelvis is. So that retroperitoneal compartment is what I'm concerned about.
And then based on the physical exam findings that we saw about flank pain, abdominal tenderness, and different findings on the skin exam, I mean, that's definitely a big concern. So now that we've gotten the CBC, what other lab work should we get? And again, this is something that we would order live altogether, but should we get an arterial blood gas or a chemistry
Sure.
or what are we thinking? Which
There's a
ones?
couple good comments on the chat before we get to that. One is any concern about brain bleed? Not at the top of my list right now because the patient is communicating with us, interactive, and you can't bleed out or die from putting that much blood in the brain. You die before you bleed out because of the pressure in the brain. And then another comment, should we put some chest tubes in? Um, uh, in this case, it's probably more just blood within the lung tissue, what we call pulmonary contusions, and not a pneumothorax because we saw that normal sliding on the ultrasound. So, not those two things I'm not concerned about.
Gotcha.
As far as your question, Dr. Katz, I would do a chemistry panel, uh, and I would do a full chemistry, not a basic chemistry, because I want to get the liver transaminases.
Order the liver function test as
Yep.
well with this Chem 7, the basic chemistry here as well. And then while we're at it too, let's get all of the other pieces of blood work that we were thinking about earlier. Do we need an arterial blood gas? Yes or no?
I'm not, you could, I wouldn't do it at this point in time.
What about
I would probably
type and screen though?
definitely type and screen.
Okay, what are we looking for on the type and screen? What does that mean?
So it gives us the ability to give type specific blood, which there's less chance of having a transfusion reaction to that. But initially, we're going to give type non-specific, which is O negative blood, until we know that type and screen.
Gotcha. So that's just a few pieces of blood work that we can order. I'm going to order them right now, and then we'll return back to the additional pieces of blood work as well and kind of make sure we're hitting on all of our points here. So
People are
let's
saying, cool, they want coags and a pregnancy.
We will definitely get to them. We will definitely get to them, I promise. So we see that the type and screen returns as O positive. So that tells us a little bit of information about the type of blood that we can give this patient, right? And then looking at the liver function test, they look pretty normal. The liver function test is something that I look at every single day as a gastroenterology fellow. It's one of the most important pieces of information that I get. But this looks all normal for this patient, which is good. What about the basic chemistry panel, the Chem 7? What are you seeing on there, Dr. Nelson?
Well, I'm concerned that the BUN and the creatinine are elevated and that the bicarb is low.
Okay, what does everyone think in the chat? What are our thoughts about that creatinine being high and that BUN being um, there?
Kidney injury? Question mark. Bad kidney? Kidney might be. Oh, there we go. Acute kidney injury, possibly hypoperfusion. Alex S., you are on fire today. I'm impressed.
All right.
Kidneys affected for sure.
But well, there we go, right? So it sounds like maybe there's a concern that the kidneys aren't getting enough blood flow.
Exactly. I mean, normally they get roughly 20% of perfusion of every heartbeat, and if you steal some of that from them, then they start to die off pretty quickly. Acute kidney injury.
So we got that. The glucose we know is high right here. What about that bicarb being 17? I mean, a normal bicarb here, it's telling us is 24 to 28. What is a low bicarbonate level telling us in the chat, if you guys can? Like, what are your thoughts when you see a low bicarbonate? This might be one of those more like almost advanced questions, even.
Right? Somebody said buffering system's not running. Acidosis. There you go. Acidosis. From what? What kind of acidosis? Acidosis, metabolic, yes. More specific. DKA? Nope, not DKA. Hyperventilate, that would be an alkalosis. Lactic acidosis. Way to go, adiajos.
All
So
right.
from
So
the lack of perfusion, from the bleeding and the anemia, the tissues are turning into lactic acidosis because they're anaerobic now. They're not getting oxygen, so the cells are doing anaerobic metabolism, producing metabolic lactic acidosis.
okay, absolutely. So that's already a lot of information. There's a few more pieces of information we can get with more blood work. So we said probably not right now to the arterial blood gas. What about a calcium ionized or calcium level regular? Is that important right now, or is that on the lower
No.
side of things we get? Okay. What about that coagulation panel?
Yes.
Okay. We'll order the coagulation panel. What about a D dimer? Yes or no?
No. No.
Okay, lactate. We talked about
Um,
lactic acidosis.
I would get it just to get a baseline because you know, we know that they're in lactic acidosis from the bicarb, but it does give us a benchmark.
Okay. So what about lipase? Do we order a lipase? Are we concerned about pancreatitis right now?
I'm not, but I would order it for a potential pancreatic injury,
Okay.
especially
Absolutely.
with the pancreas living retroperitoneal.
Yep. So we'll put the lipase order in. What about magnesium and phosphate?
Not at this moment.
Okay. What does a pro-BNP tell us, and do we need to order one right now, do you think?
ProBNP is a chemical that goes up when the heart muscle is stretched. We see that in heart failure. I'm not concerned about heart failure at this point, so I would not order it.
Fair enough. And then what about a troponin T? What is a troponin?
A troponin is a specific protein that is in heart muscle, and I would order that because there's a potential for heart muscle injury.
Interesting. Awesome. And then what about a urinalysis? Do we need
Absolutely.
Okay, we will get a urinalysis. Okay, so first we'll order that, and there's more blood work we can order in other labs that we will get to. So we'll order this first, and let's see what the results show. All right, let's see what we got here as things pop up. The urinalysis looks pretty normal, which is good. And the reason I know that obviously is because nothing's orange on it. So, a lot of the times in reality, we do look at the reference ranges that pop up in the software, and they look different, which is like, hey, that's not normal, right? The urinalysis is normal. The troponin is normal. Lipase is okay. And what about that lactate of 6? I mean, that's concerning, right?
That's very concerning. That it tells me that there's a lot of tissue in her body that's underperfused.
Gotcha. And so now also somebody had asked for the coagulation panel. So there's a few pieces of information that the coagulation panel tells us, and that's the PT, the PTT, and the INR. Dr. Nelson, what are we looking for here, and why does the coagulation panel matter, especially in this patient?
So in a patient that's acutely bleeding, especially when you're giving IV fluids, they can go into a coagulopathy called disseminated intravascular coagulation or dilutional coagulopathy, either one, where the clotting factors now are too dilute to function. And that PT-PTT is just measuring the two different arms of the clotting cascade, the direct and indirect arms of that coagulation cascade.
Awesome. So now, are they normal or abnormal? I mean, if we look at the reference ranges here, they're actually looking pretty
They look
okay.
normal.
It's good. So we've gotten all of that information, and now we want to go back to other labs because there's more testing that we can do that I was hearing in that you were mentioning in the chat, including things like more pregnancy tests and things like that. So
Correct.
let's go quickly one by one. Tylenol level, yes or no?
No,
Amylase,
no,
blood cultures,
no,
CRP,
no,
COVID test,
no.
just to make sure nobody else gets sick in the hospital. Um, I feel like that was like for
Oh
many
man,
years
yeah.
it was a test that every single person getting into the emergency room got. I think it's becoming less common now. What about a creatine kinase, a C,
No,
CSF, anything in
no,
the cerebral spinal fluid? Nope. Okay. ESR,
no.
ethanol level.
Yes,
Okay. Why do you want to get an ethanol level on this patient?
because of the potential cause of the accident.
Gotcha. So we're trying to figure out what could have happened that led to this accident. Okay. So we can get an ethanol level, lactate dehydrogenase,
Nope,
osmolality,
no,
peripheral smear,
nope,
aspirin level.
nope.
Okay. Now, serum HCG quantitative, what is that test? For everyone in the chat, what does the serum HCG mean? Because there's also, if you notice down here, a urine HCG. What are we looking for on that test? What are people
Pregnancy,
saying?
pregnancy, 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 if pregnant. Yep.
Okay.
Beta HCG.
Why does that matter in this situation for maybe things that we're going to do down the line in this case?
Well, with a potential pregnancy or not, yeah, the radiology, the potential for giving X-rays and CTs could harm the pregnancy. Medications could harm the pregnancy. Really good answers in the chat. Very good
Awesome.
job,
So,
guys.
so we have the option of doing a serum HCG with the blood work or a urine HCG. Is there any particular preference or either one works?
Either one works for me. I would order it on whatever fluid I got first.
Okay.
So if the was drawn first, I would order a serum. If the urine was obtained, a lot of times you don't get a urine right away, so um, I I will often order it on serum just because it comes back faster.
So we'll order that. Do we need a thyroid stimulating hormone,
No,
TSH? Uric acid,
nope,
urine culture,
nope,
and because we did the serum HCG, we don't need to do the urine
nope.
HCG. What about the urine tox screen?
I would for the same reason as the ethanol.
Okay, so let's perform all of those tests now. So the ethanol level is 0. The serum HCG is negative, so not currently pregnant, and also the urine tox screen looks all negative as well. Okay, so now we've done a lot of blood work, and I think that before we even move on to any imaging tests, we should start to think about, what can we, first of all, do we need to stabilize this patient still, going back to that? And then what else are we thinking? So in terms of stabilization, right, looking at the monitor again, we have a blood pressure of 94/67, heart rate of 116, O2 sat of 100%, respirations at 22, temperature is 37. What are we thinking about all of that right now?
Well, for me, I would say this patient is stable enough to get imaging, to go into the CT scanner. And then I would also start getting in my consultants.
Gotcha. Okay, so I want us to, like you said, get more tests, the CT scanner and things like that. But I think one thing that we might be forgetting is that this patient who's laying in front of us just went through an accident and might be in a lot of pain. And maybe she's not saying it
Oh,
right
yeah.
now, but what should we do to help her out while we're getting all of this testing?
Sedation, pain medication. Let's give some pain medication.
Okay.
We can also
So yeah,
talk to this patient too, right?
yeah, absolutely. In this situation, so what's really cool about this software is that we can do kind of AI discussions with certain patients. In this one, because it's more of a trauma situation, we don't do that. We're not having as much of the direct conversation. But, you guys mentioned some pain medication. So what can we give? What are some options for pain medication in an emergency room? There's a whole host of options here.
People are saying morphine, narcotics. There's a question, is the blood pressure too low for pain medication? One patient said hydrocodone and acetaminophen. I would not give that because they might go to the operating room, so we want to keep nothing in their stomach. Uh, Ketamine, morphine.
All right. What do you think, Dr. Nelson?
I would use hydromorphone. There's less of a histamine release with that, so you get less of the blood pressure drop.
Yeah, let's see what we have here. So here the options are Tylenol, etomidate, fentanyl, bolus, ibuprofen, ketamine, lorazepam, morphine, and propofol. What are your
So
thoughts on
in this scenario, I would use fentanyl.
Okay, so use a fentanyl bolus for pain
Yep,
medication through the IV, right? Okay,
correct.
so let's perform that. All right, so the fentanyl bolus was given. Now, we're gonna go get that CT scan. I promise we will get there. But we have to think of why we're doing it and what tests we want to get, right? So there's a whole option here on the left side for a differential diagnosis. And this case here, it says, has 3 correct diagnoses. So let's pick some options of what could be going on right now, what systems we should look into, and what possible diagnoses are for what's happening, which we'll confirm or kind of rule out with our further tests.
Yeah, put in the chat what you think
Yeah,
those
what are
diagnoses
some of
will.
the diagnoses that we should think about?
Pelvis fracture, sepsis, um, see, GI, cardio, blood pressure just went down. Good call.
So I heard
Internal
sepsis.
bleeding, pelvis fracture,
I heard sepsis.
renal pelvis injury,
So I heard sepsis, so we'll add that. Then I
acute
heard,
kidney injury.
let's see, acute kidney injury. We're gonna find all these. Uh,
Hypovolemic shock,
so I heard pelvic fracture. We'll add that. Okay. About let's see what other options we have here.
do they have under trauma vasculars or hypovolemic shock?
May very well be trauma vascular. Is there shock? This is our options here with aneurysms, dissections, lacerations, retroperitoneal hemorrhages.
There we go. Yeah, that's a good
Do we
one.
add that? Do you think that's relevant here?
Oh, yes.
All right, we'll add that as a possible option based on what you were talking about earlier. Hemothorax or liver laceration, is that on our
No,
differential? No, not right now. Okay. And then Let's see if there's anything else we should consider here.
Pulmonary contusion, maybe?
We can definitely do that. Pulmonary contusion, we'll add that. I want to make sure we're not missing anything. Let's see here. Renal, this is not right now what's going on. Pulmonary thoracic, right? Let's see if we have anything here. Pneumonia, pulmonary hypertension, acute chest syndrome. Doesn't sound like any of those,
No.
right? I think we have a good amount of them done. There's this musculoskeletal orthopedic section where we already talked about a pelvic fracture, maybe an open fracture. I don't know
Open
how it's
fracture.
open, but
Yeah.
we can add it on the list. Just because we want to be broad when we create a differential diagnosis. We don't want to miss things. We say looking back, oh, we should have thought about that actually.
Yeah.
Think of everything and then rule things out, then potentially miss a really important piece of the puzzle. So now we've gotten a lot of items on our differential diagnosis, and
Oh, acute kidney injury, somebody said.
I don't think that was an option to put there.
Okay, got it. Yep.
That's probably what's going on. So
Yep.
while we're going to get the test, someone mentioned the blood pressure is dropping a little bit, right?
Better check that out. Yep.
What,
What is it currently? 90?
87 over 65.
Okay. So we could give some more fluids and blood.
Should we give blood or fluids or both?
Both.
Okay, so for blood, we have again the options of packed red blood cells, FFP, platelets, and prothrombin complex concentrate or PCC. Which ones of these or all of them should we give?
Right. Good question. So I would give another unit of packed red cells, and I
Okay,
would also give FFP frozen plasma
okay, done for both of
and
those.
platelets.
And platelets.
Yep.
Okay. Do we give prothrombin complex concentrate or less important right now?
Less important now.
Okay. So we've given those, and I see, by the way, the blood pressure has responded nicely to 100 over 74. Do we also, you said, want to give some fluids here?
Yep. I'd give another liter of normal saline. And somebody said, why are we giving plasma or FFP? And it's because we're giving a lot of fluids, and when you dilute those coagulation proteins, they don't work. So we're giving some coagulation proteins in fresh frozen plasma.
Gotcha. And then you said, let's give another liter of normal saline. We can do that for sure. Let's perform it. And now we see that the heart rate has improved to 107, 104, 102. Great. That's going in the right direction. We're almost at normal. And then the blood pressure is improved to 105 over 77. So things are going in the right direction based on the interventions we're doing, it looks like. Okay.
Excellent.
Now we can get to the imaging. And so that's part of our investigations, right? And so
Yeah.
here are some options that we can do. There's the CT abdomen and pelvis. There's the CT aorta, C-spine, chest, head, pulmonary embolus CT. And then there's also the pelvic X-ray and a chest X-ray. So we may do a lot of these. Which ones should we consider?
Realistically, what would happen is I would do a chest X-ray and a pelvis X-ray in the room where they would bring the portable there.
Well, let's start with those. That's totally reasonable. Let's do a chest X-ray and let's do an X-ray of the pelvis. So the chest X-ray here shows normal lung fields, no evidence of edema or infiltrate. And because it's normal, I think we can move on from this right now. That's good to note. And then for the pelvic X-ray, the pelvic X-ray shows widening of the pubic symphysis, approximately 4 centimeters, diastasis of the right sacroiliac joint, a question of a possible sacroiliac dislocation, which can be further characterized by a CT of the pelvis. So, I mean, that's a very notable finding, right?
Correct. Yes. That's that diastasis of that joint is of the right sacroiliac joint really puts that shear stress on those pelvic veins.
So our radiology colleagues were kind enough to recommend a CT of the pelvis and say, hey, maybe that'll give us a little bit more information.
Yep.
So maybe we should do that, right? So there's a lot of options here for the CTs. So they're recommending a CT of the abdomen and pelvis, which how about we go ahead and order, right?
Let's do it.
All right, let's see what it shows us. I'm going to open it up, and it's telling us that there's an open book pelvic fracture. There's also retroperitoneal fluid collection to the right flank, no visible solid or visceral organ injury. So what's everyone thinking about that? Because, I mean, that's a very, very significant finding, right? What are we thinking in the chat?
So we have a thank you for this interesting consult. Appreciate that. This is fun. Needs the OR, ortho consultation.
All
Do
right.
we need to drain the fluid from the right flank? That's a good question. Well, we typically don't enter the peritoneum, retroperitoneal space if we don't have to. It's very difficult to get to surgically. Rarely would we drain any of that bleeding into the retroperitoneum.
Okay. So there's that. And then maybe, is there any other imaging that we need to do? Any
Yes,
CT, chest,
we,
head?
we
Which,
definitely need to do a C-spine, a CT, a head CT because of the facial bruising,
okay.
and a chest CT because of the tachypnea, hypoxia, and abnormal lung sounds.
So we're going to look for anything in the cervical spine because the patient still has that C collar on. And then also we'll look at the chest as well. So the CT of the C spine shows us this, which this is what it looks like on a side view here, normal C spine alignment without evidence for fracture, which is great news for the patient. And then also we look at the CT chest, which shows small opacities to the right mid and left lingular lung fields consistent with a mild pulmonary contusion. Okay, got it. So we have imaging. Anything else we need to do for imaging here? CT aorta or CT
I would
head?
do a CT head.
Why is that?
Because of the mechanism of injury and the bruising on the face, uh, you don't want to take somebody to the operating room to fix a broken pelvis. If they have a bleed in the brain, you might have to delay that reduction fixation.
All right. I think that's totally reasonable. Let's do it here. The CT of the head shows this view right here, which is normal without evidence of mass or hemorrhage. Okay, excellent here. So that's done there. And last thing here is there's the CT pulmonary embolus option. There's CT head and neck option. So
No,
there's a lot of different ways to possibly work this up. We've gotten a lot of blood work now. We've gotten imaging finding. We've gotten, we've done some tests and we've intervened to try to help this patient out in the resuscitation bay of the emergency room, right? But now the question becomes, what do we do next?
right. What do you guys want to do? Somebody asked, will these test choices be available in real life, or will you have to memorize them by heart before? Well, you get pretty comfortable with them because you use them every day, so they become second nature. But good question. Is the patient still awake? Do we need to talk to family? Yes, we need to talk to the family. We need to continue to maintain communication with the patient the whole time we're resuscitating. And yes, they're still awake.
Okay.
Send to the operating room.
All right. So somebody's saying send to the operating room. So to do that, though, you can't just send them off, right? You need to talk to the people who are responsible for that. So what's something we can do?
Ortho referral, it says.
Okay. So let's consult ortho first. And we're doing that because of specifically the pelvic fracture, right?
Yep. And
Okay.
I would also consult a trauma surgeon because they're going to kind of manage the whole patient.
So ortho says, I'm on my way down. She will need external fixation, ideally in the operating room. Please prepare her for the OR. And then you mentioned also a consult of a general or trauma surgeon, right?
Yep.
So let's do that. And they're saying, I'm on my way down. She sounds like she was going to need pre-peritoneal pelvic packing, ideally in the operating room. Please prepare her for the OR. So it sounds like OR is going to be where this patient ends up, right? Trauma.
We have some good comments in the chat. Lynn says, give her a gown if we can. That's great, Lynn, because when trauma patients become hypothermic, um, their coagulopathy gets worse. They don't clot. So also just because of being sensitive, right? Being attuned to the patient's, um, you know, not
Absolutely.
like exposing them inappropriately is what I'm trying to say. Warm blankets, exactly.
Um,
Tranexamic acid, Abigail. Wow, right from the battlefields we're going.
Fair enough. So there's a lot of good thoughts in the chat, right, about all of this. And so now the case asks essentially this. First of all, what's the next step for this patient? And we talked about it a little bit already, right? Is it the surgical ICU? Is the medical ICU, operating room, or telemetry floor? So I think we could all agree prep for the operating room, right?
Right. Yep.
And then we can select three diagnoses about this. What do we want to select? I mean, we picked five solid options. What are the three final diagnoses? And I think everyone should just be writing in what we should select. You let us know what the diagnoses are.
Pelvic fracture.
Okay.
See, lots of pelvic fracture. PF, that's pelvic fracture. Pulmonary contusion, and retroperitoneal hemorrhage.
All right. I think those are excellent options. And I'm going to go ahead then and hand it off to the next team. And I think I think I'll click that here, and it says we're going to prefer the OR with a pelvic fracture, pulmonary contusion, and RP hemorrhage. Are we sure? Is there anything else we need to do? Hang on, or just finish? And I think we could be settled that we're going to finish, and it's going to give us a score. And I want to warn you that we might not get 100%. Actually, I doubt we're going to get 100% because there's no 100% perfect way to do this. But let's see what it tells us how we did, and then we'll just be done with the case. Okay. 95.2. Okay, that's an A. That's a
That's an
solid,
A. I'll take
that's a
it.
solid A. I will definitely take that. We got the 3 diagnoses and we got the disposition right. The only
Woohoo.
thing we missed on is let's see what it says. Oh, so they say that a normal saline leader was harmful here extra because the patients lost a large amount of blood and maybe they want us to focus on the blood, but we did, and that's okay. We did pretty well. So I'm gonna remove my screen share here now. I'm gonna stop my share and we're gonna go back into the Zoom here. All right, you guys,
Good job, everybody.
awesome.
Team effort.
Yeah, that was definitely a team effort. It takes a lot of people in an emergency room and in a hospital to get all of this done, right? From the time EMS arrives on scene and brings the patient to the emergency room and all of the people who interact with that person on the way. There's so many steps involved, right? So kudos to all of you for helping out. Dr. Nelson, what are your thoughts about this case?
This is everyday bread and butter, real world emergency medicine. So if that was fun for you, consider that as your future career.
Yeah, absolutely. Dr. Nelson, thank you so much for that session. And we're finishing up for the day. We have a couple of minutes left. So, Dr. Nelson, you're welcome to log off. And
Thank you.
I want to thank all of you for being here today. It was a 7-hour marathon, like it always is. Like you guys have heard all day that this whole process is from starting as a pre-med to becoming a physician and practicing, doing cases like that. It is a long journey. The fact that you're all here today, I mean, it just speaks to how committed you are to this. And I want to let you know that, if you want to become a physician, you can do it. You heard from the deans today. You heard from the current medical students. You've heard from a lot of different physicians that, this is, we need more doctors. We need people who, like you, who are interested in this and who are committed. And the fact that you're spending time on your Saturday watching this is, that it speaks volumes to your future potential as a physician. And this has all been recorded throughout the day. It's going to be sent to your emails by Monday. I hope you all enjoyed it. And remember, you can watch this later on. You'll get credit for, of course, the time you spent watching all of this. And if you ever need anything, you're welcome to reach out to anybody who's been on the panels all day today. You're welcome to reach out to Med School Coach if you're looking for one-on-one advising or tutoring. I mean, that's what the company was made for. And there's so many free resources as well, like these annual events, shadowing, free shadowing online. There's all of these resources and people who want to help you succeed. So thank you all so much for being here today. And yeah, all the best and good luck. Take care.